My professors, dear colleagues, actually the purpose for my presentation is to deliver a simple message. I believe it's an old message, nothing new about it. But I believe in our current era, we should stress more upon it. As you all know, that by 10 years after CABG, about half of all saphenous vein grafts are gone. And the remainder look that they will be gone soon. Terrible. Actually, most of the saphenous vein grafts look like that. Quite nasty, ugly, and sometimes very ugly. More than that, the PCI of such conduit is limited by the substantial risk of distal embolization and no reflow, as you all know. If you escape from the no reflow, you are still prone to more accelerated atherosclerosis and instant restenosis. That's why the contemporary repeat revascularization guidelines, they advise that PCI of bypassed native coronary artery is advocated over the PCI of the diseased bypass graft. The reason is that the giant recent advances in PCI techniques, especially CTO techniques, have made this approach more applicable than before. And I will show you just two short examples of the main message of my presentation. This is quite a young man, only 6 months after CABG, presented with a crescendo angina. He had a lever to the LED, saphenous vein graft in a jump fashion to a large D1 and OM, and another one to the PDA with a mildly depressed LV function. As you see, the natives, CTO of the CX, functional occlusion of the LED just before a sizable septal and quite a sizable branching diagonal, and retrograde to the PDA. So his native RCA is occluded as well as its saphenous vein graft. And this is the jump saphenous vein graft to a large OM and a large diagonal. As you see, a long subtotal bifurcating occlusion. Surprisingly, actually, the surgeon, I don't know why, inserted the lima on the small LED instead of the large diagonal. Anyway, it looks like this is the culprit, of course. And although it's a bifurcating saphenous vein graft, but I believe it is not a big deal, it will not take a lot of work. But actually, we decided to invest more in this young man's future and try with the natives better. So we started with the LED, I mean to the diagonal. This is a functional occlusion. Workhorse wire passed easily to the septal, but not easily to the diagonal. We used the filter XTA that passed to a branch of the diagonal and then pre-dilated. And after that, the workhorse wire can pass with some difficulty, but again to the branch of the diagonal. And after some manipulation, we could fish actually the real or the large diagonal proper, fortunately, as you see. And then removing the filter, pre-dilatation, multiple preparation, actually you see a long disease of quite a large diagonal. that required a lung stenting. Then after that, as usual, multiple optimization with NC balloon, and you got a good result in a very large native diagonal, which after opening it, actually, it enhanced a lot the collateral circulation, both to the PDA and more importantly, to the CX, actually sparing us from getting another access site for dual injection. So I started actually with a fielder, it failed, so I used the penetrative wire pilot 200, but actually it passed to the side branch. It penetrated the proximal cap, but it passed to the side branch, as you see here. So I used a kind of a side branch technique by dilating towards the side branch. Sometimes it's called sesame technique, I think. And it worked actually by opening a channel to the true lumen of the CX. It's quite a large CX. So, but unfortunately, the fielder could not negotiate such a channel. It always went intra-plaque, as you see in this view, because the plaque is overhanging over the channel. So I used a sort of a reversed wire technique, looping the fielder in the distal branch, and then pulling it back, it prolapsed into the CX, fortunately. After that, we encountered another occlusion in the distal CX before the sizable OM branch, and actually the fielder could not negotiate the occlusion except with the knuckle. So we trusted the knuckle actually, and as you see here, the knuckle will pass, but not to the distal OM, but to the occluded graft, as expected. With the knuckle, always go to the side branch. But now we can predilate proximally, and after predilatation, we could modify the position of the wire distally, and then after preparation, stenting, and after stenting, as usual, good optimization, and we end with such a very acceptable result for the two large natives. This is the end result of this case. I will show you also rapidly another case for the same principle. This is a patient with CABG in 2011 presented us with unstable angina. He had a lever to the LED, esophageal vein graft to the OM1 and OM2, and his right coronary artery was judged by the surgeon to be small enough not to require a graft at this time, I believe. As you see, his natives, quite complex, left main, extensive disease extending to the CX with its bifurcation of the two sizable OMs, and the LED also extensive disease, but it's protected by the lemur, a patent lemur actually. And here, show you how is the extensive disease in the natives. The CX looked to be a large dominant, giving some collaterals to what appears a small RCA, which is also extensively diseased. Anyway, the lemur was patent. The saphenous vein graft to OM1 looks degenerated, having a distal anastomotic lesion. And another saphenous vein graft, OM2, has a subtotal flap-like mid-lesion that appears to me that this is the culprit for the unstable angina. So this actually, it's a 10-minute job. It can be fixed easily, at least as a culprit lesion. But again, I elected actually to do it the complex way, but more for the future of this patient. And we decided to tackle the extensive disease of the natives. The wire passed first to the OM2 and easily, but to the OM1 was quite difficult, always passed to the graft because of the anastomotic lesion. We used the parallel wire technique, and it worked actually. And then protecting the LED as well, although it's already protected by the leber distally. And after multiple preparations of the lesions, we decided to stent the OM1 to the left main, as you see here, but we ended up by losing the OM2. So fortunately, I was lucky to get a quick distal recrossing for this OM2, as you see here. And then after opening the struts, we achieved the flow back, and we did a bailout tap, as you could appreciate here. Unfortunately, it is a long stent again, but the disease is extensive in OM2. We completed the tap, and then after meticulous optimization with NC balloons, we ended up with a final pot with a 5mm balloon in the left main ostium. And we ended up after slightly more than an hour with such a good result for the left main, proximal CX, and the bifurcation as well in these two important OM branches. And this was the final result. So, Mr. Chairman, actually, I believe with the advances we have in PCI techniques these days,
right.
I believe that the PCI of such lousy conduits, the saphenous vein graft, will be abundant in the near future.
Yeah.
Maybe only limited to the STEMI patients, right, or to do a retrograde conduit to a CTO.
Right.
That's why, actually, until we have a randomized studies, which are ongoing now, my message is please do less saphenous vein graft, and even if it is easier, and please do more natives, even if it is more complex.
Thank you.
Thank you very much.